Good morning, one and all. My name is Dr. J. Lionel John. I am Fifth Unit Chief of the Department of Orthopedics in Sree Balaji Medical College and Hospital. Today's topic we are going to discuss about proximal femoral fractures. One of the major issues in clinical practice is femoral fractures, and it's very common and in elderly people and in younger age group. So most of the times why it is important, because it involves various segments of one single part of the femur, that is the proximal femur. And some of its variants are like head of femur fractures, neck of femur fractures, intertrochanteric and subtrochanteric fractures. These fractures play a major role in treating the patient because it occurs at various levels and treatment depends upon various modalities depending upon the type of fractures. A hip fracture can cause injury to one or four areas of the upper femur, namely femoral head, the ball of the femur that sits in the socket, the femoral neck, the area of the femur below the ball, that is the femoral head. Intertrochanteric area is the area below the neck of the femur and above the long part or shaft of the femur. It is called the intertrochanteric fracture because it is marked by two bony landmarks, the greater trochanter and the lesser trochanter. And next is the subtrochanteric area, the upper part of the shaft of the femur below the greater and lesser trochanters. What are the risk factors? Age, risk the double over the age of about 50 years, and sex, women are prone to have fractures more than men, that is 2 to 3 times. Race, the Caucasians having more than 2 to 3 times, and some use of chronic steroids and chronic medical illnesses and medical history of previous hip fractures. Head of femur fracture. Femoral head fractures are rare traumatic injuries that are usually associated with hip dislocations. Diagnosis can be made by pelvis, hip radiographs, but frequently require a CT scan for surgical planning. Treatment may be non-operative or operative depending upon the location of the fracture and degree of fracture displacement. What is the classification? Pipkin's classification. Type 1 is below the capitis femoris. Type 2 is a fracture of the femoral head superior to the fovea centralis. Type 3 is similar to type 1 and type 2 but associated with fracture of the femoral neck. Wherein type 4 similar to type 1, 2 and 3 but associated with fracture of the acetabular rim. What is the treatment for femoral head fractures? Pipkin's type 1 and 2 conservative treatment or open reduction internal fixation with a headless screw, that is the Hubbard screw. Pipkin's type 3 open reduction internal fixation of neck of femur with femoral head, and in old age group it is arthroplasty. In Pipkin's type 4 it's fixing the acetabular first followed by femoral head fixations. Neck of femur fractures. The neck holds the femur fracture away from the pelvis. It is formed by the cancellous trabecular bone and reinforced with the cortical bone, particularly on the inferior portion. The age distribution is bimodal. Elderly has even a low energy trauma. It causes an impacted fracture, whereas in young, high energy trauma, an impaction is very unusual. Most fractures are displaced with distal fragment externally rotated, adducted and proximally migrated. It is caused by the pull of the muscles on the superior aspect of the femur. There is an anatomical classification for neck of femur, that is type 1 is a subcapital, type 2 is transcervical, type 3 is basicervical. Another classification is Gardner's classification, depends upon the trabecular network, and that is the stage 1 is an undisplaced incomplete and including a valgus impacted fracture, whereas grade 2 Gardner's type 2 It's an undisplaced, but it's complete fracture without disruption of the trabecular pattern. Gardner's type 3, it's a complete fracture and it's incompletely displaced. Type 4 is a complete fracture with completely displaced fracture of the neck. Powell's classification is one of the another classification which is well oriented and relevant. That is type 1, and that is drawn on a horizontal line over the head of femur and another line over the fracture line over the neck of femur. It makes an angle, if it is an angle of 30 degrees, it is stable, and 50 degrees it is less unstable, whereas 70 degrees it is more unstable fracture. Intracapsular hip fractures, the treatment modality, that is the femoral neck fractures. There are two types, undisplaced and displaced. Whereas undisplaced, the fixation in all age groups unless symptomatic arthritis before fracture. So if it is undisplaced, mostly it is asymptomatic. Whereas displaced fracture, and there are no risk or any osteoporosis, reduction, open reduction and fixation. Whereas high risk and the medical comorbidities are more, then it is a total hip replacement is an option. Age above 40 years with alcohol abuse and significant medical comorbidities, then unipolar or bipolar fixation is augmented. Whereas displaced fracture in older patients, straight total hip arthroplasty is done. And in case of less mobility patients, we go in for a bipolar hemiarthroplasty. What is the treatment modality for Gardner's type 1 and type 2? Since type 1 and type 2, they do not disturb the blood supply to the femoral head, so no need for any mechanical stabilization unless for a compressive screw fixation is more than enough. Whereas Gardner's type 3 and 4, it disrupts the blood supply 30 to 50%. So the femoral neck fractures management differs upon the type of Gardner's 3 and 4. Mostly the third and fourth goes for AVN, and we go in for a hemiarthroplasty or total hip replacement depending upon the age and the medical comorbidities the patient carries. Intertrochanteric fracture, most common in elderly people, and it's an extracapsular fracture of the proximal femur between the greater trochanter and lesser trochanter. Equal frequency in men and women, and they are often comminuted. Painful, shortened, externally rotated lower extremities are present clinically. What's the classification? Boyd and Griffith classification. Type 1 are stable, type 2 is unstable and comminuted, type 3 is unstable reverse oblique, type 4 is intertrochanteric with subtrochanteric with it's a two-plane fracture. Evans classification. Type 1 is undisplaced two-part fracture, type 2 is displaced two-part fracture, type 3 is a displaced three-part fracture with a posterolateral comminution, type 3 is a three-part fracture with a large posteromedial comminution as a fragment, and type 5 is displaced four-part fracture with comminution involving both trochanters. Radiographs are recommended, that is AP view of the hip and a cross-lateral and a full-length femur, and as well as CT or MRI if there is a negative clinical examination with the fracture. Treatment modalities. Usually we do a proximal femoral nailing or a dynamic hip screw fixation, and depending upon the age and the severity of the fractures, we even do an arthroplasty. Subtrochanteric fractures, it's usually defined as an area from the lesser trochanter to 5 centimeters distal. Classification, Russell-Taylor classification. Subtrochanteric fractures, that is fractures not extending to piriformis fossa, fracture extending to piriformis fossa. To the piriformis fossa, the lesser trochanter is intact, wherein the other is lesser trochanter is also involved as a fracture fragment. Whereas in the fractures extending to the piriformis fossa, lesser trochanter is intact, lesser trochanter is also involved. There are two types depending upon the fracture pattern. Schenshammer's classification. Grade 1, any fracture with less than 2 mm of displacement. Grade 2A, two-part transverse but minimally displaced, whereas grade 2B, two-part spiral with lesser trochanter in the proximal fragment. Grade 2C, two-part spiral with the lesser trochanter in distal fragment. And grade 3A, three-part spiral, third fragment is a lesser trochanter. Grade 3B, third part and the third fragment is a butterfly fragment. Grade 4, 4 or more fragments. Grade 5, any fracture with extension into the greater trochanter. Treatment modalities is usually we go for intramedullary nailing, that is a cephalomedullary nailing, and a fixed 90-degree angle blade plate as shown in the picture. Thank you. Now I have talked about various modalities of treatment for various fractures of the proximal femur, and I would like to enlighten or summarize most of the points which has been talked in this few minutes of my talk. Invariably, the fractures have been classified into head of femur fractures, neck of femur fractures, intertrochanteric and subtrochanteric fractures. And the modalities of treatment depends upon the various types of fractures. It varies from simple fixation to joint replacement surgeries. I hope I have given vivid examples for you to understand, and I hope you would have understood most of the topic. Thank you.